Dear Chairman, delegates, ladies and gentlemen, I must again express my sincere apology for not attending this Euro Fair 2019 because I got a flu a few days ago, and although I'm feeling better now, but still I cannot attend. So I have to do my job and take this video to present to you. The topic for my presentation today in plenary is many phases of Botox in urology. For decades of investigation of the clinical application of Botox in urology, Botox has been widely used to treat DSD in spinal cord injury patients and refractory idiopathic overactive bladder, interstitial cystitis bladder pain syndrome, and lower urinary tract symptoms due to BPH or bladder neck dysfunction, chronic pelvic pain syndrome, CPPS, and neurogenic or non-neurogenic lower urinary tract dysfunction in children. Only the first two indications are licensed to use. The other treatments are still in investigation and off-label. Regarding the mechanism of Botox action on lower urinary tract symptoms, it is the heavy chain of Botox A binds to the SV2 on the neuronal surface. Then internalization of the toxin into the nerve terminal, and the light chain of the Botox A cleaves synaptosome-associated protein 25, so-called SNAP25, and that inhibits signal transmission by disrupting the fusion of neurotransmitter containing vesicles. So Botox can also alter the release of ATP, neurotrophin, and the nitric oxide in the urothelium. So this is the nerve terminal and Botox effect on the neurotransmitter release. Even in the urothelial cell membrane, there is a SV2A expression. So if we instill Botox into the bladder and the Botox can be delivered into the urothelium, it can also work on the urothelial receptor and to inhibit the transmitter release from the urothelial cells. So we can see after Botox injection, the SNAP25 will be cleaved, and also we can detect the cleaved SNAP25 in the urothelium after Botox injection. That means the SNAP25 has been cleaved by the Botox protein. The motor effect of Botox on lower urinary tract dysfunction include inhibit the release of acetylcholine from parasympathetic nerves. Botox can block the release of acetylcholine. So in human with neurogenic detrusor overactivity, the bladder M2 and M3 and the P2X2 and P2X3 receptors can be reduced after detrusor Botox injection. So botulinum toxin A can inhibit detrusor overactivity by acting through inhibition of both the sensory and motor arms of the micturition reflex. After Botox injection, we can see the bladder capacity increased, but the detrusor contractility was reduced. So patients have to use abdominal strain at the termination of the urination to completely empty their bladder. However, the vesicle will reform after Botox injection. So the symptoms usually recur at 6 to 9 months after Botox injection. And we have to repeat injection to ensure patient can have a good therapeutic efficacy. Regarding the sensory effect of Botox on lower urinary tract dysfunction, intravesical injection of Botox can effectively block ATP as well as acetylcholine release, which is postulated to ameliorate acute pain and urge sensation. So Botox significantly inhibit the release of ATP and the neurotrophin from urothelial cell and increase nitric oxide release. Pain reduction and anti-inflammatory effect is also the pharmacological action of mechanism of Botox. Botulinum toxin A could block the TRPV1 trafficking to the membrane during bladder inflammation and inhibit the inflammatory sensitization of TRPV1. An intravesical Botox injection could reduce both urinary nerve growth factor and brain-derived neurotrophin levels in IC-BPH patients and render an analgesic effect. So Botox administration to the red bladder can also decrease the amount of spinal cord C4 protein expression due to chronic bladder inflammation. So clinical application for avoiding dysfunction include the detrusor sphincter dyskinesia and avoiding dysfunction in spinal cord injury patients and multiple sclerosis patients, including neurogenic and non-neurogenic detrusor underactivity. If we inject Botox into the urethral sphincter, some patients might have a detrusor contraction recovery after Botox injection. And for patients with multiple sclerosis and CVA, and their urethral sphincter cannot relax properly during voiding, Botox injection into the urethral sphincter can also improve their voiding dysfunction. And for male patients due to BPH, bladder dysfunction, urethral dysfunction, Botox injection can also relax the urethral sphincter and bladder outlet smooth muscle to decrease the bladder outlet resistance and to facilitate spontaneous urination in these patients. In the beginning, Botox was used to treat patients with spinal cord injury or multiple sclerosis and DSD and to facilitate urination. However, after the treatment, usually patients will have a more severe urinary incontinence. So after that, patients began switch to detrusor injection to become continent, but they have to use clean intermittent castration to empty their bladder. However, the quality of life improvement in detrusor injection seems better than the urethral sphincter injection. So nowadays, most of the patients with NDO were treated, and NDO and DSD were treated with detrusor injection rather than treated by the urethral sphincter injections. Regarding the prostate injection, although it is clinical trial did not show a significant benefit of the Botox injection in treating lower urinary tract symptoms, but Botox injection still can be used in patients who have large prostate, urinary retention, and cannot accept surgical interventions. After Botox injection, we can see the shrinkage of the prostate gland, and the patient can resume spontaneous urination. And we inject Botox into the prostate and followed by a continuous 5-ARI medication, patient usually can maintain a good spontaneous urination after treatment. For the storage lower urinary tract dysfunction, Botox can be used for NDO due to spinal cord lesion, idiopathic OAB, and pediatric NDO or non-neurogenic OAB. And patients can have an increase in maximum bladder capacity and decrease in urgency frequency episode. And some patients require CIC due to the increase in post-void residual and difficult urination, especially in the first months after Botox injection. For patients with spinal cord injury with a high level, higher than a T6 level, we should be cautious of the autonomic dysreflexia during Botox injections. And after Botox injection, the urinary symptoms will improve and the bladder capacity will increase. And reflex volume, bladder capacity in spinal cord injury and NDO also improved after Botox injection. Currently, the recommended dose for the Botox injection for the NDO is 200 units on botulinum toxin A. However, if patients receive 300 units Botox, usually they will have a less instance of uninhibited detrusor overactivity at about 9 months after injection. So if patients who have failed the initial 200 unit Botox injection for their NDO, maybe we should try 300 unit Botox for the subsequent Botox treatment. So the EAU guideline for the LUTD also recommend strongly to use Botox injection for NDO refractory to medical treatment. Regarding the glomerular filtration rate to improve renal function, at first we hope that continuous Botox injection in spinal cord injury with NTO might have play an important role to protect the upper urinary tract function. However, in the 2 years short-term clinical trial, we cannot demonstrate the beneficial effect of the Botox injections for the glomerular filtration rate improvement. But the renal function can maintain in good conditions. And for the patients with non-neurogenic detrusor overactivity refractory to anticholinergics, Botox injection can increase bladder capacity, decrease voiding pressure, but slightly increase the post-void residual. The detrusor overactivity can be decreased to about 30 to 50% at 6 months after injection. And for patients with OAB, a double-blind dose ranging trial have suggested that 100 units can be used as the best the dose to balance benefit and safety in general OAB patients. And for patients who have a large post-void residual or who are very old, frail, and maybe very weak, we may inject Botox into the bladder base, including the trigone, but not the bladder wall. Although the therapeutic duration is shorter than that injected into the bladder body, but none of the patients injected to the trigone area develop chronic urine retention or difficult urinations. So another application of Botox is the inflammatory-related lower urinary tract dysfunction, including BPH and chronic prostatitis. And previous studies have shown that patients who suffer from bladder pain and a small bladder capacity can have a pain relief and a decrease in the frequency episode and symptom score after repeated Botox injection into their bladder body. And in IC-BPS, we know that nerve growth factor expression increased in the bladder wall, and after Botox injection, the NGF expression will decrease after treatment, and which is associated with the pain relief and symptom improve. Now, which neurogenic bladder patients might be suitable for a starting dose of 100 unit Botox? Some patients who have a spinal cord injury, multiple sclerosis, who do not wish to use clean intermittent castration after treatment. A patient with Parkinson's disease, multiple sclerosis, who had OAB symptoms but can urinate spontaneously and completely. And patients with SCI or MS who have NDO and low detrusor contractility. Patients who have NDO and autonomic dysreflexia but can void adequately. These patients might benefit from only 100 unit Botox and continue to urinate spontaneously without the necessary to use CIC to empty their bladders. Regarding adverse event and risk factors, we know that dose-dependent UTA, UTI, urinary retention, spinal cord injury patients may have autonomic dysreflexia, and elderly patients OAB who has a large post-void residual at the baseline should be cautious in treating Botox because they might develop a large post-void residual and a subsequent urinary tract infection. Especially in the first months of the injection, the voiding efficiency decreased and the post-void residual increased. So we should take care of these patients. If they have a large post-void residual more than 250, we may suggest them to do clean intermittent castration to empty their bladder. And for elderly, frail patients, Botox injection in these patients might develop a large post-void residuals. And what patients is not a good candidate for detrusor Botox treatment, including severe ISD, severe contracted bladder, like high-grade VUR, cannot catheterize, and severe AD during detrusor injection. And patients highly expect to urinate spontaneously after treatment, such as high-grade reflux and ISD. And so in these patients, maybe we can try in the future the experimental trial of the liposome encapsulated Botox causing lipotoxin. Using intravesical infusion of lipotoxin, the bladder capacity can be increased, and also the detrusor overactivity can be reduced. In human clinical trial, we also demonstrate that liposome-encapsulated Botox for patients with OAB, patients can have a decrease in frequency episodes. However, the duration is too short, about 3 months. So this is still a clinical trial and have not been clinically applied. So take-home message, botulinum toxins suppress detrusor overactivity, moderate sensory function, inflammation, and glandular function. Botox has gained approval for urological use in the treatment of NDO and OAB, and patients experience less urgency and urinary incontinence, which are associated with better quality of life. Adverse events such as large PVR, AUR, UTI are common. Patients must be well informed, and frail patients and DHIC Botox injection should be used cautiously to prevent AUR and the subsequent UTI. Again, I must express my sincere apology to you for not coming Singapore to attend Euro Fair. However, I hope you can understand my situation and welcome you to Taiwan, to Hualien, and to my hospital. Thank you.